Hello everyone. So we are discussing a new topic, gestational diabetes mellitus, GDM for short. We are going to look at the definition, diagnosis, management and complications. So first, coming to the definition. GDM is defined as carbohydrate intolerance of variable severity with onset or first recognition during pregnancy. Carbohydrate intolerance of variable severity with onset or first recognition during pregnancy. We need to keep that in mind, because this is, I can't just say carbohydrate intolerance or something. It's carbohydrate intolerance of variable severity with onset or first recognition during pregnancy, because it is that important. It is diagnosed irrespective of whether the condition persists after pregnancy. The disorder commonly manifests in the second or third trimester and is associated with impaired beta cell function. More than 50% of women diagnosed with GDM later develop type 2 diabetes over a period of 15 to 20 years. But the definition is restricted to these two lines, so that should be enough. Coming to diagnosis. So diagnosis is essential for managing maternal and fetal health effectively. The criteria used includes screening tests, glucose tolerance tests and postprandial glucose monitoring. So three things: screening, glucose tolerance, and then where is the next one? Postprandial. The postprandial should be here somewhere. Yeah, postprandial is here. Glucose tolerance and postprandial levels. Postprandial glucose monitoring. Yes. So first one, screening. Screening is done for all pregnant women between 24 to 28 weeks of gestation. Women at high risk are obese women, advanced maternal age, previous history of GDM, family history of diabetes, macrosomic baby which is greater than 4 kilograms should be screened earlier. So coming to the screening specific, so there is something called as glucose tolerance test, wherein 100 gram oral glucose tolerance test is done after an overnight fast. Blood samples are taken at fasting and 1 to 3 hours after consuming 100 gram of glucose. The diagnosis is made when at least 2 values exceed the following limits. So at least 2. This could be this or this, this or this, this or this. So what are the limits? Fasting is greater than 95. First hour after the ingestion is 180 milligram per deciliter. After 2 hours is 155. After 3 hours is greater than 140. 95, 180, 155, 140. It keeps decreasing because it keeps getting unloaded into the tissues. It can't stay there in the blood. We know the mechanism already from biochemistry. Alternatively, 75 gram OGTT can be performed and 2 hour postprandial glucose level of greater than 140 over here, 140 milligram per deciliter is diagnostic. But since here it is the higher glucose number 100, this one is the limit is higher. But here, since the number is lower, the limit is also lower, 140. So we have taken a look at glucose tolerance test. So these are the two main key things which we look at. This one, I think, screening tests and glucose tolerance tests. These are the only two things, but this thing is included under this. Coming to management. So treatment specific, what do we do? Management of GDM includes dietary modification, physical activity, blood glucose monitoring and pharmacological intervention if required. So dietary management. First one, diet of 2000 to 2500 kilocalories for a normal weight woman and 1200 to 1800 kilocalorie per day for an overweight woman is recommended. So 2000 to 2.5 k, and here it is 1.2 k to 1.8 k kilocalories for an overweight woman. Carbohydrates should make up 40 to 50%, protein should make up 20 to 30 and fats 30 to 40. 40 to 50, 20 to 30 and 30 to 40. Frequent small meals, 3 major and 3 snacks help prevent postprandial hyperglycemia. We don't want sudden overload of glucose in the bloodstream. Coming to exercise, moderate aerobic exercise such as walking 30 minutes per day improves insulin sensitivity and helps control blood glucose levels, which is self-explanatory. Resistance training is also beneficial in overweight women. So this one is very good. Resistance training, weightlifting. Blood glucose monitoring. target blood glucose levels for fasting should be less than 95, 1 hour postprandial less than 140 milligrams per deciliter, and 2 hour postprandial less than 120 milligrams per deciliter. So these are the target blood levels what we are looking at. We want this to drop to this level. So by doing other things. So if the value exceeds these limits, we do insulin therapy. Coming to insulin therapy, indicated if fasting blood glucose greater than 95 or 2 hour postprandial greater than 120 milligrams per deciliter despite diet and exercise. So this is the first line attack from the doctor side, diet and exercise. If these things don't work, we go for insulin therapy. Human insulin is preferred due to its safety. Combination of short acting regular insulin and intermediate acting NPH insulin is commonly used. Regular NPH. Insulin pumps or multiple day injections may be needed in severe cases. And then we have oral hypoglycemic drugs. So metformin, glyburide are alternatives when insulin is not preferred, but insulin remains gold standard for GDM. And then coming to the complications. GDM increases the risk of complications for both mother and the fetus. So there are maternal and fetal / neonatal complications. Coming to maternal complications, increased risk of preeclampsia, polyhydramnios leading to preterm labor, recurrent GDM in future pregnancies, increased risk of type 2 diabetes later in life, operative delivery due to macrosmia and cephalopelvic disproportion. This one makes sense. So I will be going through these in more detail. This one diabetic ketoacidosis, this one makes sense, and infections because increased blood glucose leading to increased substrate for the bacteria to grow. So these three things, recurrent so these two things we need to have some idea as to what the mechanism is, so that we remember how it works, so that we can write it. Why is it a complication in GDM? GDM leads to multiple so why preeclampsia? Endothelial dysfunction causes chronic hypoglycemia leading to oxidative stress and systemic inflammation. This damages maternal blood vessels and make it more prone to vasoconstriction and hypertension. So similar mechanism which is seen in normal human beings. So diabetes, increasing the risk of hypertension, increased insulin resistance and vascular dysfunction, poor placental vascular remodeling. Similar to preeclampsia pathogenesis, so remodeling is affected and placental ischemia leading to these particular mediators, increase in these anti-angiogen leading to hypertension, proteinuria, and there is kidney stress, increases the GFR, placing additional stress on renal system, combined with hypertension predisposes to proteinuria, worsening preeclampsia. Preeclampsia is a condition with hypertension along with proteinuria. So that is increased because GFR is increased due to GDM. So that makes sense now, preeclampsia. Coming to polyhydramnios, fetal hyperglycemia, increased urine production. In that sense, yes, it makes sense now. GDM, excess maternal glucose across the placenta leading to fetal hypoglycemia, excess of insulin and increase of which acts as growth hormone and increases fetal metabolism. More of glucose is released into the urine causing osmotic diuresis, excessive urination and polyhydramnios. Now it makes much more sense. So over distension of uterus because of increased amount of amniotic fluid triggering uterine contraction and increasing the risk of premature labor and premature rupture of membranes. Severe polyhydramnios can also cause umbilical cord prolapse and placental abruption. So this is something else. But overall we are clear why these two things happen in GDM. Next, coming to fetal / neonatal complications. So fetal macrosmia, well known complication, it increases the risk of birth trauma, not blood trauma, shoulder dystocia. Neonatal hypoglycemia due to fetal hyperinsulinemia after birth. So fetal hyperinsulinemia we have already seen, increased glucose in fetal blood leading to insulinemia. RDS due to delayed surfactant production, which is especially in this particular case in diabetic case. Polycythemia, hyperbilirubinemia, increased risk of neonatal jaundice. This one we need to check once. Congenital malformation, increased risk of cardiac defect, neural tube defects and choroid regression syndrome and stillbirth. Poorly controlled GDM is associated with intrauterine fetal demise. So we'll take a look at last three so that we are clear with what the reasoning is. Why in GDM? So polycythemia, chronic intrauterine hypoxia leading to placental function, same function, same mechanism leading to fetal hypoxia. Hypoxia stimulates increased EPO leading to excessive fetal RBC production. Polycythemia, increased breakdown, hyperbilirubinemia. Makes sense. Now teratogenic effect of maternal hyperglycemia. This is something new. So hyperglycemia in early pregnancy disrupts embryonic development, inducing oxidative stress and apoptosis. Cardiac defects like TGA, VHD, AVHD, atrioventricular. Neural tube defects, anencephaly, spina bifida, and caudal regression, abnormal lower spine and limb development. Stillbirth, poorly controlled GDM is associated with intrauterine fetal demise. So same thing, hypoxia here, metabolic crisis and hyperviscosity leading to thrombosis, leading to demise. Yeah, now it makes sense. Coming to management during labor and postpartum. Intrapartum, postpartum. Intrapartum induction of labor is considered at 38 weeks if well controlled, earlier if complications arise. Caesarean section is indicated in cases of macrosmia, fetal distress or maternal complications. Caesarean section is indicated in cases of macrosmia, fetal distress or maternal complications. Blood glucose monitoring every 1 to 2 hours during labor. Intravenous insulin and glucose infusion to maintain blood glucose between 100 to 120 milligrams per deciliter. So we know the intrapartum management, 38 weeks if earlier if the complications arise, macrosmic baby, C-section, fetal distress or maternal complications. Blood glucose check every 1 to 2 hours and intravenous insulin and glucose infusion to maintain blood glucose between 100 to 120. Postpartum management, blood glucose levels normalize postpartum, but monitoring is essential. OGTT at 6 weeks postpartum to rule out persistent diabetes. 6 weeks postpartum OGTT. Women with GDM should be advised with about dietary indications, modifications and lifestyle changes to prevent, because we know long term increased risk of type 2 diabetes. So we want to prevent that. Contraception counseling to prevent unplanned pregnancies, especially in insulin dependent cases. Yes. So with this we come to the end of a discussion on GDM. In case you like this particular video, you can like it. In case you would like to watch more of such videos, you can subscribe. I have been recording these videos repeatedly, continuously and repeating the same thing over and over, and very good at saying it. Okay then, bye bye.